Imagine going to a doctor in just agonizing pain, like you've been dealing with it for months. The clinician takes a swab, puts it under a microscope, and finds this terrifying lack of healthy bacteria, plus a soaring pH and obvious, deep tissue damage.
Right.
So based on this, they write you a prescription. You go home, you take the medicine, and absolutely nothing happens. I mean, your pain just continues.
Yeah, it's a terrifying scenario for any patient, honestly.
And why does it happen? Because the treatment you were given is the exact opposite of what you actually need.
And sadly, it happens far more often than we'd like to admit in this specific area of medicine.
Yeah. So today, welcome to our deep dive. We are jumping into the absolute diagnostic muddy waters of women's health.
It really is muddy.
It is. We're looking at a medical mystery where two totally distinct conditions present themselves in almost the exact same way. And for this deep dive, we're pulling from primary care portals, medical diagnostic laboratory criteria, and expert reviews from gynecology and menopause journals.
Some really robust sources.
Exactly. And our mission today is to figure out how medical professionals basically play detective to differentiate between these two look-alike conditions.
Yeah.
So one is active desquamative inflammatory vaginitis, which we're just going to call DIV for short.
Yes, much easier to say.
Right. And the other is profound postmenopausal estrogen-depleted tissue thinning, which is often called atrophic vaginitis or genitourinary syndrome of menopause, GSM.
DSM, yeah.
So by the end of our conversation, you're going to understand how clinicians navigate a space where standard lab tests literally lie to them.
They absolutely lie. And, to really grasp how difficult this diagnostic puzzle is, we first need to understand the actual mechanics of what's happening in the tissue for both of these conditions.
Right, because they end up looking the same, but they start from completely different universes.
Exactly. Let's look at atrophic vaginitis, or GSM, first. This is a condition driven almost entirely by hormone depletion.
Mostly happening after menopause, right?
Sure.
Though I saw in the sources it can also happen during lactation, or if a patient is taking anti-estrogen drugs for something like breast cancer.
Yeah, any scenario that drastically cuts estrogen. I mean, the transition into menopause leads to an approximate 95% decline in estradiol concentration.
Wow, 95%.
It's massive. And the tissues of the vagina, the vulva, the lower urinary tract, they are absolutely packed with estrogen receptors.
Right.
They rely on that hormone to function at all. So when you remove 95% of that estrogen, the mechanics of the tissue fundamentally crash. The vaginal epithelium, the lining, basically it stops maturing.
Okay, so the superficial epithelial cells, which are like those thick top protective layers, they essentially just stop growing.
Yeah, and they can completely disappear in severe cases.
It's, think of estrogen as a building maintenance crew. While the crew is there, everything works. The walls are thick, the plumbing works, the structure is sound. But when the estrogen leaves, the building falls into this profound disrepair. The walls get paper thin, the plumbing dries up.
That's a great analogy.
And the sources mention that connective tissue underneath actually changes too, right?
Oh, yeah. The structural degradation is fascinating. Well, and devastating. Without estrogen, the collagen fibers in the tissue actually swell and hyalinize.
Hyalinize?
Yeah, meaning they take on a glassy, rigid, almost scarred appearance. They literally fuse together.
Oh, wow.
The elastin fragments, the tissue totally loses its ability to stretch or, produce normal secretions. The organ is essentially shrinking and becoming rigid.
Okay, so that is our first culprit.
Yeah.
Profound neglect and disrepair due to a missing maintenance crew.
Right.
But then we have the second culprit, DIV. And based on what I'm reading in the sources, DIV isn't just disrepair. It's like a fire in the building.
That is the perfect way to visualize it. DIV, or desquamative inflammatory vaginitis, is an incredibly severe, rare, and chronic inflammatory condition.
Desquamative refers to the severe peeling, right, or the shedding of the vaginal wall.
Yes, the tissue is actively sloughing off.
And the most maddening part, to me at least, the root cause is completely unknown.
Completely unknown, yeah. We have theories, sure, but no definitive answer. But we do know the demographic it targets.
Right.
It primarily hits perimenopausal white women.
Which means it targets the exact same demographic that is starting to experience the estrogen drops of atrophic vaginitis.
Exactly.
I mean, if you are a woman in your late 40s or 50s, you are squarely in the crosshairs for both of these things.
And that age overlap is the very first trap for a clinician. You have a patient walk-in complaining of severe dyspareunia, painful intercourse, alongside general vaginal discomfort, burning, and irritation.
And the demographic fits both perfectly.
Yep. Physical symptoms fit both.
So the doctor does what any logical professional would do, right? They
Mhm.
turn to the lab, they swab the tissue, and look under a microscope.
Yeah.
But this is where the diagnostic train totally derails.
It completely derails.
Because if one condition is a lack of maintenance
Mhm.
and the other is an active inflammatory riot, shouldn't they look completely different on a cellular level?
I mean, you would certainly hope so. But under the lens of a standard wet mount microscopy, the similarities are just staggering.
How is that even possible?
Well, let's look at the mechanisms of a healthy vaginal ecosystem first. In a healthy state, the dominant bacteria are lactobacilli. They are the guardians of the tissue. And they survive by feeding on glycogen.
And glycogen is basically a sugar stored in those thick, healthy, estrogen-fed superficial skin cells, right?
Precisely. So the lactobacilli eat the glycogen and produce lactic acid as a byproduct.
All right.
This keeps the vaginal pH nice and acidic, usually below 4.5. That acid barrier is what protects against invasive infections. But think about what happens in our two conditions. In atrophic vaginitis, the estrogen is gone.
So the thick cells are gone,
Right, and the glycogen is gone.
which means the lactobacilli literally starve to death.
They starve. The healthy ecosystem is obliterated. And because there is no lactic acid being produced, the vaginal pH skyrockets to an alkaline state, well above 4.5 or 5.0.
Okay, I follow that mechanism for GSM. But why does the pH skyrocket in DIV? I mean, estrogen is theoretically still present there, right?
It is, but in DIV, the massive inflammatory response and that violent shedding of the tissue we talked about, it physically destroys the environment where the lactobacilli live.
Oh, I see.
Yeah, the inflammation wipes them out just as effectively as starvation does in atrophy. So in both conditions, the pH hits 5.0 or X.0.
So a clinician swabs a patient in pain, sees a pH of 5.5, and learns absolutely nothing about which of the two diseases they're actually looking at.
Nothing at all. They just know the acid barrier is gone. So they look closer at the slide, they do a wet mount to look at the actual cells, and they immediately encounter what we call the parabessal cell problem.
Ah, the vaginal maturation index.
Hmm?
This was heavily featured in the laboratory criteria we reviewed for this deep dive. It's basically a measure of how mature the skin cells are.
Right. In a normal environment, the cells that shed naturally and end up on a microscope slide are the mature superficial cells from the very top layer.
Thick ones.
Exactly. Parabasal cells, on the other hand, are immature cells from the deep foundational layers of the tissue. You really shouldn't see many of them on a surface swab.
But the architecture of the tissue in our two culprits guarantees you will.
Yeah.
Right? In atrophy, the top layers just don't exist anymore because they stopped growing without estrogen.
Yep.
And in DIV, the top layers are being violently burned away by inflammation.
So in both scenarios, the deep, immature parabasal cells are suddenly exposed to the surface and they slough off onto the microscope slide.
Wait, I have to push back on this whole process. We have a patient suffering from chronic pain. They have a high pH. They have no healthy bacteria. They have a slide full of deep tissue parabasal cells. And one of our sources literally says, quote, "The wet bound of atrophy is identical to that of DIV."
It does say that.
If the slides are identical, isn't a doctor just making a highly educated guess at that point?
Yeah.
I mean, how is this considered a definitive diagnostic process if the fundamental lab results are just a coin flip?
If the clinician refuses to look past the microscope, it absolutely is a coin flip. And the consequences of that coin flip are devastating.
I can imagine.
Patients with DIV often suffer for 15 to 31 months, bouncing between multiple doctors, trying multiple failed treatments before finally getting a correct diagnosis.
15 to 31 months.
Yeah. The psychological toll of being told you have, a simple postmenopausal issue or a generic bacterial infection, while the pain only worsens, it's profound.
A year and a half to over 2 years of untreated severe inflammatory pain. That is a massive failure of the diagnostic process.
Which is exactly why the skilled clinician has to zoom out. They have to step away from the lab results and look closely at the physical presentation, the visual tissue exam, and the specific nature of the symptoms. That's how you start pulling these two diagnoses apart.
You have to look at the whole building, not just the bricks on the slide.
Yes.
So let's talk about the first major divergence in the symptoms, the fork in the road.
Yeah.
Moisture versus purulence.
This is a critical distinction that relies on the patient's lived experience and the visual exam. Atrophic vaginitis, at its core, is profoundly dry.
Right.
Because the tissue is thinned and the blood flow is reduced, vaginal secretions drop dramatically. The patient will often complain of a sensation of intense dryness, like sandpaper rubbing against their clothes.
Ouch.
But DIV, on the other hand, is an exudative process. It produces a copious, purulent, sticky discharge. It's often yellow or greenish.
Going back to our analogies, atrophy is like a dried-out, pale riverbed. But DIV is this swollen, weeping rash. The sheer volume of the discharge shouldn't make sense if it was just atrophy.
Exactly. When the clinician performs a physical exam with a speculum, they're looking for the mechanism behind that discharge. With profound atrophy, the visual is stark. The tissue looks incredibly pale, smooth, and shiny. It lacks the normal folds, called rugae, that allow the vagina to expand.
And because it's paper-thin, it's incredibly fragile. The sources note that simply touching an atrophic vagina with a speculum can cause it to tear and bleed.
It can. But the bleeding in DIV happens for an entirely different reason. When you look at DIV, the presentation is far more aggressive.
It's not pale.
No, the tissue is fiery red. You'll see spotted rashes, petechiae, which are tiny pinpoint bleeding spots, and areas of ecchymosis or bruising. You might even see linear erosions.
I want to break down those linear erosions really quickly because the underlying mechanism is wild to me. Why would the tissue form bleeding lines? It's because the immune system is literally attacking the tissue.
Yeah.
The white blood cells are stripping away the upper layer so aggressively that the skin breaks down into tiny bleeding trenches. It's not tearing from friction like atrophy. It's being eaten away by inflammation.
The immune system is essentially localized friendly fire here. But even with these visual clues, the muddy waters haven't totally cleared.
Oh, right. Because atrophy can sometimes become inflamed too.
Exactly. The tissue can show patchy redness.
Yeah.
It's why it is sometimes called atrophic vaginitis, not just vaginal atrophy.
So a really inflamed atrophic vagina could theoretically look a bit like DIV, especially in a perimenopausal woman who might actually be experiencing both simultaneously, like her estrogen is dropping and she just happens to be developing this rare inflammatory condition.
Which brings us back to your earlier frustration, right? How do we move from an educated guess to absolute certainty?
Yes. How do we?
Well, to get definitive proof, the clinician has to look for a very specific microscopic ratio and then perform what is basically the ultimate medical lie detector test.
Let's talk about that ratio first. So we're back to the wet mount slide, but we're looking past the missing bacteria and the parabyssal cells. What is the clinician hunting for now?
They're looking at the white blood cells. While an inflamed atrophic vagina might show some white blood cells indicating a mild immune response, DIV features a massive, overwhelming immune invasion.
Okay.
The clinician calculates a specific metric, the leukocyte to epithelial cell ratio.
Yeah.
If that ratio is greater than 1.1, meaning there are more white blood cells on the slide than there are actual skin cells, it points heavily toward DIV.
A 1.1 ratio is staggering. I mean, the immune cells are outnumbering the structural cells.
And these white blood cells often look activated or toxic.
Yeah.
Furthermore, in DIV, while the normal lactobacilli are gone, you'll often see an opportunistic overgrowth of specific aerobic bacteria.
Like what?
Things like E. coli, group B strep, or Staphylococcus aureus. It's a completely different microbiological profile than the barren, dry lymph.
The sources are incredibly clear about one thing. DIV is a diagnosis of exclusion.
It is.
You have to definitively rule out atrophy before you can formally declare it as DIV. And the way they do this absolutely blew my mind.
Yeah, it's quite the process.
The sources state that a trial of adequate local estrogen is essential to differentiate these two conditions. You have to actually treat the patient to figure out what disease they have.
It is the ultimate diagnostic trump card. Because the cellular overlap is so significant and visual exams can be, subjective, you prescribe a localized vaginal estrogen treatment.
We really need to pause and appreciate how wild a trial by treatment is in modern medicine.
Yeah.
We don't do this for broken bones. A doctor doesn't look at an x-ray, scratch their head, put a cast on your leg for a month, and say, well, if it still hurts in 4 weeks, I guess it wasn't a broken bone, maybe it's a torn ligament. The fact that medical science has to rely on trial and error here is staggering.
It definitely speaks to the limitations of our current diagnostic tools in women's health, but clinically speaking, the estrogen trial is incredibly effective.
Okay, how so?
Well, if the patient is suffering from atrophic vaginitis, the local estrogen acts as a direct cure. Over a few weeks of application, the tissue absorbs the hormone, the
Mm.
cells begin to mature again.
The glycogen returns.
Exactly, feeding the lactobacilli, the pH drops back down, the acid barrier is restored, and the patient heals.
The maintenance crew comes back, fixes the building, and everything works. The pain stops.
But if the patient uses the local estrogen for an adequate amount of time and it does absolutely nothing for their symptom,
Nothing at all.
right. If the discharge continues, the fiery redness remains, and the pain persists. It confirms the diagnosis of desquamative inflammatory vaginitis.
Because if it's DIV, estrogen is basically useless. It's not a hormone problem, it's an inflammatory riot.
Adding a maintenance crew to a building that is actively on fire doesn't put out the fire.
Exactly. DIV requires a totally different, much more aggressive medical intervention. The standard of care shifts to a prolonged course of 2% clindamycin cream or potent topical corticosteroids, like 10% hydrocortisone, inserted directly into the vagina.
So you are no longer trying to rebuild tissue, you are dropping chemical fire retardants to suppress a runaway immune response.
And because DIV is chronic, many patients require ongoing maintenance therapy with these medications just to prevent a relapse. If you stop the steroids, the immune system often just ramps right back up.
It's a clinical tightrope walk. Think about the stakes of getting this wrong. If a clinician sees a high pH, spots some white blood cells, and assumes it's a severe bacterial infection, ignoring the possibility of simple atrophy, they might prescribe heavy oral antibiotics, which is very common.
And that won't cure the atrophy, but it will absolutely decimate whatever fragile flora the patient has left, potentially triggering massive yeast infections and plunging the patient into even more pain.
Or, conversely, assuming it's just menopause and giving estrogen to a DIV patient, leaving them to suffer with severe inflammation for another agonizing month while you wait to see if the trial works.
Yeah.
It requires incredible patience, keen observation, and frankly, humility from the clinician. They have to understand that the lab tests don't always tell the whole story.
This entire journey is a masterclass in how medical science navigates uncertainty. It highlights the absolute necessity of patient advocacy,
Absolutely.
If you are a patient and a doctor tells you it's just one thing, but the treatment isn't working, you have to push back. You have to demand they look past the microscope.
And interestingly, the scientific community is actually starting to look past the current definitions altogether, which brings us to some of the most cutting-edge research in our source material.
Yes, before we wrap up this deep dive, we have to talk about the final, highly provocative thought from the researchers. It completely reframes every single thing we just discussed. It challenges the very name of the disease itself.
The name desquamative inflammatory vaginitis implies a standalone, unique disease entity, but several prominent researchers in our sources argue this name is a misnomer. They suggest DIV isn't a unique disease at all.
Right. They propose it is actually just the extreme end of a spectrum. They categorize it under a condition called aerobic vaginitis.
Aerobic vaginitis is a broader classification where the normal lactobacilli are replaced by aerobic pathogens, accompanied by varying degrees of inflammation.
So what are they suggesting about DIV then?
What researchers are suggesting is that DIV is simply the most severe manifestation of this. Think of it as a score of 8, 9, or 10 out of 10 on the aerobic vaginitis severity scale.
So instead of being its own mysterious isolated condition, it's just the absolute worst case scenario of an aerobic bacterial imbalance. But the implications go even deeper than that. The sources hint that viewing it solely as a localized bacterial issue might also be entirely wrong.
Look at the mechanism of the cure. The fact that DIV responds so rapidly and profoundly to topical corticosteroids, which, remember, are medications specifically designed to suppress the immune system that strongly suggests an immune-mediated etiology.
Right.
It may not be an infection in the traditional sense at all. It may be an abnormal, localized, systemic attack.
This is the part that truly stops you in your tracks. An immune-mediated systemic attack. I mean, what if this condition isn't an infection you catch from an external bacteria?
Exactly.
What if it isn't just a random localized imbalance of flora? What if DIV is the body's own immune system abruptly declaring war on its own vaginal microbiome?
If it is an autoimmune spectrum disorder, it fundamentally changes the future of women's health treatments. We move away from the paradigm of just trying to kill off bad bacteria with antibiotics and instead focus on modulating the immune system itself.
Wow.
It requires a completely different pharmacological approach.
It's incredible. You look through that microscope and you think you're just looking for a simple bug, a tiny pathogen you can eradicate, or, a lack of hormones you can simply replace. But instead, you might be looking at a microscopic civil war.
And until we fully understand the triggers of that civil war, clinicians and patients will have to continue navigating these muddy waters together, relying on rigorous observation and, as we've seen, trial and error.
It just goes to show whether you're dealing with a 95% drop in hormones or an unexplained autoimmune riot, sometimes the most important thing a clinician can do is admit that the diagnostic picture isn't black and white, listen to the patient's lived experience, and just keep digging.